Refugee backgrounds. We're going to be exploring through conversations what access and inclusion looks and feels like in the healthcare system from different experiences, right? Because I know what my experience is because I'm in this forum, but I need to be curious and cultivate understanding and attenuate my listening so that I can appreciate others' experiences, right? And that's a practice. That's outside of biochem. Right, that's what it looks like to be in relationship with people, and to have a meaningful relationship that is impactful and powerful and collaborative. So we have a great group of panelists here today that I want to recognize. It takes a lot to come up and like sit at the front of the room and share your story bravely and deeply. So I am so appreciative and thankful for each of you willing to do that for us today and to be in conversation about what access and inclusion in the healthcare system looks like. And also we recognize that you own your own narrative, you own your own story, and by no means are you speaking for a general population or everyone that may have some way of identifying with this topic, right? So sharing authentically and powerfully is much appreciated. Yeah. This Patient Voice series is put on by the Office of Health Equity and Inclusion here on our campus under the leadership of Dr. Jose Rodriguez. And they're a great team, awesome team. If you want to learn more about health equity and inclusion, just look at their website. I'll give it at the end of the presentation. This particular topic is sponsored by the College of Health, that's my college, and the Department of Nutrition and Integrative Physiology, that's my department, I'm the Associate Director. And also our EDI officer, Equity, Diversity, and Inclusion officer. Glad to be here today. We have some learning objectives because there's CMEs and credit and we're an academic institution and let's talk about learning. So number one, we really want to distinguish between access and inclusion in the healthcare system. They are distinct and unique and they look and feel differently in action. We want to develop an understanding of effective techniques to communicate across difference, recognizing that the way that we perceive and communicate is not how everyone else perceives and communicates, so how can we bridge that, especially in the health. And understand ways to obtain resources in regard to patients with refugee backgrounds or intersections of identity, knowing that identity is complex, and there's resources available. Often the burden of education feels like it's on the person, but really the burden of education should be on the clinician, should be on the individual healthcare provider. Use healthcare services and to actually have the need for services fulfilled. Okay, so that's access is interfacing with the system, right? The healthcare system is extraordinarily complex. We all know this, and it's one thing to measure the barriers or identify the barriers, and it's another thing to remove them. And so access is about removing barriers, okay, to receiving healthcare services, and then inclusion defined to all people, regardless of their abilities, disabilities, or healthcare needs, have the right to be respected, appreciated as members of their communities. So inclusion. I have the special honor to introduce our moderator for our panel today. Dede Ramba is the president of, you got a panel. I didn't get a, I'll step out of the way. Dede Ramba, the president of the Refuge Group.
All right. Thank you, Sarah. I'm really excited and honored to be here this morning or this afternoon to be a part of this wonderful event. So like you just heard, my name is Dede Ramba and I'm going to be moderating this event. But before we do that, I'm just going to give each panelist a chance to just mention their name, and then we come back to me, talk a little bit about my background, and then we go back to the panelists, and then they'll talk a little bit about their backgrounds, and then from there they'll share their stories. So you want to start?
Yeah, my name is Madalena James.
My name is Leslie Sapea Charia.
My name is Evariste Kabura.
My name is Julie Muki.
Thank you. So My name is Dedi. Like I said, originally I'm from South Sudan. I came to the US in 2004 as a refugee, and I'm excited to recognize a couple of faces in the audience. That's why I got the wow, which is good. And I'm also an alumnus of University of Utah, Health Promotion and Education. But my role here today is because I'm kind of involved with the refugee community, and I founded a nonprofit organization that is kind of trying to address certain health issues in the refugee communities. So we are fortunate enough to get a grant from the Department of Welfare Services to implement an exercise challenge program to get refugees to be active and eat healthy and live the healthy lifestyle and be productive people of this community. So that's all about myself. But the name of the organization is called the Refugee Group. It's still new. We're still working on the website, so don't go ahead and Google it out because you won't find it. But maybe after a week or two, try to Google it up and you'll see what we are and what we do. It's called the Refugee Group, and we hope that we'll continue this collaborative work together and try to be of help to people, as many as we can. Thank you.
Hi. So I was born in Sudan, and my family took refuge in Egypt, and we used International Rescue Committee to help us resettle in Salt Lake City, Utah, and we came here in February 2000. So next year will be my 20th year living in US, and I grew up here. I go to University of Utah. I'm a fifth-year student, senior. I'll be graduating in fall 2020, and next month I will start studying for my MCAT and take my MCAT in the summer. And my major is biology, and my minor is chemistry, and I like to dance and cook.
Hi, my name is Leslie again, and I'm from Colombia, Bogota, Colombia. I came to the United States 10 years ago, in June of 2009. I came as a political asylee because my mom was here, and you're a teenager, you need to be where your mom is. So she fled Colombia due to political disturbances, but mostly because some people wanted to kill her, and kind of like a movie. So we came here, and I did 1 year in high school and learned English. It was hard, but I did study here at the University as an undergraduate. I did medical anthropology as my major, and minor in human biology. I used to be pre-med when I was in undergrad, but then changed my mind and went to student affairs in my grad program that I just finished. And currently, I'm an undergrad research advisor here at the U, and I work in the Office of Undergrad Research.
Okay, again, my name is Evariste Kabura, and I am a refugee from Burundi, but I was born in Rwanda. My parents are from Burundi. They fled the country in 1972, and they fled to Rwanda. I was born in Rwanda. And in 1994, we fled again to Tanzania. And I grew up in Tanzania in a refugee camp. And from 2007, we were resettled in the United States here in Utah through IRC. And I was back home, back in Tanzania refugee camp. I used to be a teacher, and in here I taught the ESL. That was like 4 years, and I became interpreter in 2013. Been working with refugees, like interpreting Swahili, Kirundi, Kinyarwanda, and French since 2014. That's all.
Okay, hi. My name is Julie Mukiri. I came to the US in 2015. My intention was to have my baby delivered in a safe place because she was my 6th pregnancy. I had 5 miscarriages. So we decided, let's go and find out other ways of trying to get a baby who has a good condition or a healthy condition. I've never made it to 9 months. She's my only full-term pregnancy. So for that reason, that's why I decided to come here. It was a big argument between me and my husband asking me to come here so that I'm safe, and if there's anything, I'll get good medical attention. So that's the reason why I was here in the US. I did business administration. I was working back home. I had a good job. I was working as an office manager. So up to now, I'm still in the US only because of my daughter's medical condition. And if you want to Google about medical facilities and medical health back home, please go and Google health facilities in South Sudan. Then you'll understand the reason why I'm here. Thank you.
All right, thank you so much. And without further ado, I'm just going to get to Madalena to start sharing with us what access and inclusion means to her. And then from Madalena, who will go all the panelists first and then take questions. Or one panel, yeah. So after all the panelists are done sharing their stories, then you can start asking questions. So Madalena, the floor is yours.
Okay, so what access means to me is the ability to engage between healthcare providers and refugees, asylee patients, and ability to pay for services and satisfaction are essential to improve these patients' healthcare experiences. Is to have primary care providers remind the patient their safety and security, offer interpreters if it's possible, deeply engage with the patients about their symptoms, their stories, and guide the patient how to seek for more resources on how to treat their symptoms and their treatments with or without health insurance and Medicaid included. So that's my perspective. My healthcare experience has been really great. The bad experience was when I was in high school. I had a hard time with self-anxiety, self-doubt, lots of negativity, and I went to my wellness checkup. And when I was there, and my healthcare provider, I was trying to talk to my healthcare provider, but I guess it was during the afternoon. I sensed a really bad energy or bad vibe, as in the healthcare provider seemed like she was in a rush, and I did not feel safe. And I just told her how I was having a hard time in school, with self-anxiety, and how I was unhappy in school, and that just disrupted my relationship with my family, with myself. And my healthcare provider advised me, like, should I do hobbies or join a sport athletic club? And I tried to listen to my doctor's advice about it and follow their advice, but it was ineffective because I have a minor heart condition. It's called atrial septic defect, and according to the Mayo Clinic resource, it is a hole is in the hole between two upper chamber of my heart, and this condition is a birth congenital condition, and I had a larger hole in my heart that could not be corrected when I was an infant, so I had open heart surgery at the age of 11, and they corrected it, and I was impressed with that. And after I figured out my heart condition, I knew that I could not participate in intensive athletic sports. So my healthcare provider at that time advice was ineffective for me. That was my bad experience. My good experience is just recently, last year, I went to a cardiologist for my 11-year after checkup to see how well my heart is. And I went there, the intention was to join the military, and see how effective my heart was. And my cardiologist and physician assistant, they were really great. They answered my questions, they explained what was going on in my heart, they taught me about what's going on in my heart, and I was just at ease, relaxed, calm. I knew what was going on with my heart, so that was a good experience. So what Access looked to me is engaging deeply about my story, my past health experience.
Okay, thank you.
So for me, so as I mentioned before, I came to the United States 10 years ago. So I came as a teenager, and when my mom was here before me, so as soon as I arrived, my first experience with healthcare was translating for my mom. So we speak Spanish, although like that's kind of like quote unquote the biggest historically marginalized group in Utah. We see a lot of lack of health providers that are culturally relevant and have cultural experience that are similar to us or do speak Spanish, if that makes sense. So we do try to with translators, but sometimes it's best for me to go and translate, and that's a burden for young people to have, and it's stressful, especially when already you're trying to adjust to a new place. So that's kind of my experience when I arrived to the United States. But to mention what I mean by medical or healthcare access, what it means to me it means that medical and mental care access for refugees and asylees need to be more culturally relevant and responsive. Refugees and asylees communities need to be more represented and more healthcare providers and professionals. What I mean by that is that we have people that look like us and speak like us or have cultural similar backgrounds. Doesn't mean that we have the same story, because it's not. We all have, and we should own our own stories, but it just have someone that you can relate. Then also have these communities, not that I'm trying to talk for all communities, but what I have observed in my experience, healthcare providers are willing to deliver healthcare with an understanding of our intersecting identities that we hold as refugees and asylees. So we have mentioned a lot what refugees and asylees are, those terms, but I don't know if you know what it is, but refugees are people that fly their country according to the UN, either for war or for poverty, or they're fleeing because they're displaced from their home. And they look for a place of refuge so they can have like basics, the civil rights that they have and the basic needs that could be met. But the difference between refugees and asylees is where you get the legal status. Refugees, they receive the legal status from the United States, outside of the United States. Usually it's through governmental organizations that are internationals or non-governmental organizations who help them with the process. Asylees get their status here in the United States, so they apply when they are in the United States. So you will see now, like in the news, there are a lot of people that are fleeing their countries due to poverty and war. So it's very hard when people that are supposed to be refugees, they receive that legal status. So that's another identity that we hold. Many of us hold, could be legality or no legality, and having that political identity that we have. Then also health providers need to acknowledge that resiliency of these communities and the issues that impact them. So I mentioned immigration. So anti-immigrant sentiment is another one. Racism is another thing that impacts us. And that way, health providers that are culturally relevant could advocate with their patients in their health and have a more equitable and inclusive health process. So that's kind of my take when it comes to health access. One of my experiences recently is that I know it sounds like family, but many times I go to the doctor with my mom, right, to accompany her. And one time, a doctor, we couldn't find a person that was Latina, so of course I have to go. Then, which is okay, I'm happy to do it. Then we were asking, because my mom has kind of weird things in her back, like little balls of fat, I think they are. And the doctor, he said, "Oh, that's okay. That's nothing to do. That's okay. That's normal." And we were denying testing, so they didn't proceed with testing. And now she goes to a doctor again, and they have to tell her, oh, this could be dangerous, but let's do testing. So knowing that, although I understand that doctors are busy and sometimes there are many patients at the same time, now I know that when a doctor or a healthcare provider doesn't deny a testing that I think my body needs, I can ask them to record in their chart that they deny my testing. So later on, if something happens, it's in record. So, but I didn't know that back then. So there's a lot of things that kind of trying to navigate that system, navigate different people, and making sure that people are receptive to trying to, that we understand also our bodies. Then insurance and be able to pay for healthcare. Although I'm very fortunate to have the insurance here at the University of Utah, that doesn't mean that my mom has the insurance of the U. She has another insurance. So for her, it's more expensive to pay for any healthcare stuff. I'm relatively healthy so far, but we always get scared every time that my mom has something because we have to pay a lot of money for it. So that's kind of like my experience with healthcare, and I really hope that it helps me something. Yeah.
Okay, again, my name is Evariste Kabura. I'm interpreter. Like I said before, I've been interpreting for refugees since 2013. So I've been having a lot of experience with working with refugees, seeing what they need in healthcare because I've been a medical interpreter. I've been seeing like people having like a lot of barrier like to access like the healthcare, like lack of money like to pay their bills. Then they're afraid of going to see the doctors because they don't have money like to cover their bills, and some they might be on Medicaid but they don't have copayment, and that way they have that barrier like to access like the healthcare. And there are some because of most of the refugees that I've been working with are new in the country. They don't know the address, and they have a problem of lack of transportation. Like they cannot go to see the doctors sometimes because they don't have transportation, or they don't understand like the way to arrive to the appointment. And there are some refugee population that they have like an appointment and they become to the appointment late because of transportation. And also I will talk about the interpreters or interpretations, and some of the refugees, they are having issues with the interpreters because they may be speaking like, let's say, I'll give an example, like in my community, we speak Kirundi and Swahili. And sometimes there's different Swahilis. They may, there is a Swahili from Tanzania. They may be speaking Swahili from Congo, and the interpreter is from Kenya or from Tanzania. In that way, it's going to be a big problem to understand. They will not understand. The communication will not go through. And there are some people that also talking about the interpreters. There are some people like they are from Central African Republic, since they have their native language like Sango, and they don't have enough interpreters. Then they decide to say that they speak French, but their French is not enough to communicate. In that way, that's a barrier with the interpreters. And like I said, I've been in a refugee camp for my entire life. The refugee camp we lived in, it's my personal experience. It's like a crowded refugee camp where there is like a lot of people. In that way, many people are overstressed. They have stress because in their home country. That's why because they fled the war and the violence, and they are in a refugee camp. In a refugee camp, also sometimes they don't have enough food or water, and they are overstressed also in a refugee camp. Arriving, if they get a chance to get resettlement to come to United States, sometimes most of the refugees are overstressed here because they cannot speak English and they don't understand anything about the healthcare. And sometimes most of the refugees, they have low education. So they have their belief in order to access the healthcare, it's really hard for them to understand. Like here, back home, the healthcare here and healthcare back home, there are some refugees that even though they get the medication, they don't use the medication because back home they used to be using their traditional medication. It's another barrier. And sometimes I may talk about some providers. Even there's another problem with the providers. They are not patient with the people, with the refugee people. Sometimes they may be feeling like they are discriminated in many different ways since they don't speak English, or they don't understand, the way of healthcare. So coming to my experience in access and inclusion, I think that helping refugees and being patient with them, they will help them to feel welcome in this culture. Knowing their culture, where they are from, or what they believe, or how they are, is going to help them also.
Thank you. Sorry, I have cough, so I don't want to stretch my voice. I don't know that this is not working.
That doesn't mean to the room. It's for the recording.
Oh, it's for recording. Oh, okay. Okay, so I'll just try to raise up. Okay. Okay, thank you so much. My experience is a personal experience, but also giving an overview of the background where I came from. Medical facilities or medical access is not adequate. And that's why I presented myself before telling you that the reason why I'm here is because of medical access. Back home, for people who can afford, you will have the money and you'll not be able to have any kind of access to medical facilities or medical coverage or whatsoever. Here, it's the opposite. The access is there. But how after accessing it, what next? That's the question. So in my context, when I came, I came with sufficient funds to cover me living in the US, covering my medical cost for 1 month. I planned for it because I just didn't get up. So when I went, the day that I had my baby, my experience was really bad because it's like no one wanted to attend to me. I was telling them that I was in pain, but they told me that I wasn't dilating, and for that reason, they cannot even see me. Like they tell me to go back home. I say, I'm not going anywhere from here. It's me who knows myself and what's going in me. I could hardly raise my feet or my legs to move. So I told them, can you call the doctor? Call my doctor. My doctor's supposed to be here. So they were like, they don't call doctors at this stage. They'll call the doctors when I'm ready to have my baby. I say, that doesn't make sense for me. I've been seeing my doctor for over 2 months. I've just seen you today, you don't know about me. So my doctor has a better understanding of who am I and what I'm experiencing. So it was really tough, and in the process, everything went wrong. Like my baby's heartbeat stopped. The monitor all went blank, and then they gave me what do they call it? Epidural. And then when I had that epidural, I wasn't feeling anything. My water broke, and no one knew. The nurses were just sitting wherever they were sitting. So, I'm sorry, I'm getting emotional because it reminds me of that day. And so I was in panic because this is my 6th pregnancy. And I came all the way thinking that I'll get a better attention. Now I'm here and no one is taking care of me. So I'm asking myself, why did I travel all the way here? So then when my water broke, the nurses were not aware. This is the first time for me to deliver. I've never delivered any child. So I don't know what is water breakage or anything. So by the time they came, they were all looking at themselves, and I was in a bad shape. I was really, really swollen. You cannot believe. I have pictures of that. I was trying to pull so that you feature it, but I didn't have time to do that because my internet was really slow. So they came, they were looking at themselves. I knew that something was wrong through their emotional communications. So the next thing I saw was that they brought pints of water and had to, like the way drip goes into your body, they inserted it and they had to have that water go in me so that my baby floats. But I was thinking, my baby is not breathing now. Can you address the breathing thing first before the water? What will the water help? How will the water help her? Call the doctor. They never called the doctor until 7 a.m. I was in the clinic I was at the hospital. That was San Mark Hospital. I was there from like around 3:30 until 7 a.m. in the morning. That's when the doctor came. No, the doctor came in between, sorry. He came in between and he told me that, okay, it's taking long, but whosoever is covering today, the doctor in charge is his best friend. He has been working with her all this time, and he knows that she would help me. When that doctor came, she also introduced herself to me. That was the last time I saw that doctor until today. Even while I was in pain, I was like, okay, call for me the doctor that my doctor asked her to help me. They told me that she went to another hospital. I was like, I thought she was the doctor in charge today at this hospital. That means she has to stay here until another doctor comes and take over in the morning maybe. So I'm in pain. She's in another hospital and she promised to help me. And that's the reason why my doctor is not here right now. So everything went wrong. My baby inhaled meconium, and that's what causes her breath to stop. And they tried to put the water. It wasn't working anyway. I don't know how I survived, and my baby survived until today. When the doctor came, he saw me all swollen. He decided, can you take her immediately to the theater? Within 5 minutes, they rushed me to the theater. After that, I felt myself light, and then I was like, doctor, I didn't hear any cry. Did I have my baby or I had a stillbirth? And the doctor was, no, your baby is fine. If my baby is fine, why am I not hearing her voice? She's supposed to cry. That's what we know when you give a birth to a baby. That's what we're taught, and that's what I heard. So he told me that she will be fine. Just take care of yourself. So then my heart sank. I was like, I've already lost my baby and he doesn't want to tell me, maybe. So after like 40 minutes, I had a cry, only one cry, and that was it. That was the end of it. They took my baby immediately to the emergency, to the ICU. So my baby was in the ICU, and after that, they took me to the recovery room, and I was like, I need to see my daughter. When I went, I found my daughter is like a spider web. So my daughter was like here, and they plugged all sorts of things on her, and there's really sophisticated machines all around her, and I don't know what that was for. So I was like, is this baby going to survive or what? So after 12 hours, the pediatrician came to me and told me that, you know what, we don't have better facilities in St. Mark Hospital. If you permit, we'll take your daughter to a better hospital. At that stage, it was hard for me to separate my baby, but I decided, take her anywhere. I just want her alive. So I don't know what happened. I saw 9 doctors coming in, and all of a sudden they brought the incubator, and I think they came on a helicopter. And that helicopter, the incubator had some kind of technical fault, so they had to bring back the incubator and get another one. But the only thing that made me happy was like all the doctors came and everyone was going to attend to my baby in the area of his or her specialty. So those who were working, looking at her heart, her eyes, her respiratory system, different kind of doctors came to the scene to help her. And that made me happy. Even after all the sad story that I had, at least now I have people who can help my daughter. So then she was flown to the primary hospital. In the primary hospital, it was like, I had to stay there until the 3 days and then join my daughter. It was really tough for me because I didn't expect this to happen. I was thinking that I'll have a healthy baby, stay here for 1 month, take my baby back home and continue with my normal life. So now the doctors were telling me stories, were telling me the facts now. Like, it's not easy and your daughter's going to stay longer than you expected. So then what am I going to do? That's all what I'm calculating in my mind because I had a specific time frame. I had limited financial assistance that I would have helped myself with. So my daughter stayed there for 3 months. My daughter's bill is like 2.6 million and she was still in the hospital. So the other thing that I'm happy about the accessibility is, even despite of that, the hospital has like good plans in place to help educate people about what else you could do. And if your situation is like this, they always have a plan A and plan B. And they are called the social workers. I was so happy about that because I was renting and my baby was at the hospital and I rely on my friends who are here to pick me and drop me to see my daughter every day and take me back home. If they are not there, I have to get a taxi. And when I get into a taxi, coming to the hospital and going back is like $80 in a day using a taxi. So everything was like going. I've been blessed. I had a good job ever since I graduated back home and I saved a lot. This situation took us to 0. And even after that, we were not able to complete our medical bills. We cannot afford it. I told the doctors, I said, even if I work for the rest of my life until I die, I will not be able to raise that money. So the social worker told me that we have a program here called the financial assistance. You can apply for it and everything. So we applied for the financial assistance and I'm grateful for the hospital and for the Americans and the taxpayers who were able to donate into this hospital to give people who are unprivileged like us the opportunity to meet their expenses. So this is one thing that will never happen in my country and also in the neighboring countries, because my country is worse. Going to the neighboring countries to seek medical attention is something else. But if you don't have money, no doctor will look at you. You'll not even come to the reception. You'll not even think of going to the doctor or to any clinic. No one will even touch you or talk to you. You put your money first, that's when they'll talk to you. And even after addressing that issue, like doing a surgery, if there are any other follow-up that needs to be done, if you don't have the money, they leave you at that stage. So if I have to have my baby back home, I wouldn't have a baby by now. 3 weeks after I had my baby, they told me that she was Down syndrome. They didn't tell me during the pregnancy. Everything was fine. So after that, they told me, I say, she's okay for me. I need a baby. Well, that's what I need. I need a baby and a baby who's alive. I don't want a dead baby. So my baby grew up and later on they discovered multiple things. She had a respiratory issue. She has 5 holes in her heart. They fixed one. She has 4 that are not yet fixed, but they say as she grows, they will be able to, it will close on its own. So, and then she's feeding on a G tube until today. She cannot take anything liquid with her mouth. And there she is. She's now at school. She's 4 years. She goes to the preschool. She goes to the Head Start after that. And after that, she goes to a daycare. Then I pick her when I'm done after work. So when I look at this and also how the hospital helped me get like papers to legalize my stay here. Until now, I have a work permit and I have a job to rent a house and, provide for my daughter. I'm grateful for that. This is something that will never happen like in other countries. So while there are some hiccups in the process, but at least I always tend to look into the positive aspect than the negative aspect, so that we'll know how to. When you dwell on the negative, you'll not move. But when you dwell on the positive, you'll always be positive and move on. So that is my story about my daughter and her medical bills. I started paying the rest. I started paying it until it went to collections. I last completed my bills 2 months ago. But the other thing also about access to medical facility, he mentioned that some of the refugees are afraid of going to the hospitals is because they don't have that, they're not educated, they're not informed about other options. There's a clinic here called the Malihe Clinic. It works with the University of Utah. And if you're a medical student, I would encourage you to please go and put some volunteering time in there, because it helps people who do not have access to insurance, or they have insurance but they don't have the copay, and that makes them not to go to the hospitals. And these people say living in the US, they have kids. So now they are ill and then they don't get themselves educated. Their kids will grow up also in the same environment. And then you'll have a population of like people, let me say, like in my country, the gap between those who are not educated and those who are educated is really big. But in between here, there should be a class that at least could survive, But in the next 20 years, maybe, the situation in the US will be almost the same situation in Africa if they don't address some of the issues that we are flagging up. Because of the population that they're bringing in and because of the status of the people that they're bringing in, it will be the same in like 20 years. So if things are not addressed at the right time, then it will be difficult in the future when it's out of your hands. So this is my experience with my daughter.
Thank you so much. Time just flies so fast. I'm surprised we're at 12:45. Is there any chance we can?
Have 15 more minutes.
Okay. So without wasting time, just a couple of things that I want to mention. As I was listening to the panelists sharing the stories, I've noted down some things that if you have a question or you're trying to answer a concern, please see if you can address or incorporate that into your answer. And just like Sarah was saying, it's one thing to measure the problem and it's totally something else to remove it. So if you can address those issues in your questions or comments, that would be good. Like, let me start with Madeline here. Her overall experience is kind of good, except for she mentioned something about, the healthcare provider at the time was in a rush and that kind of stuff. I don't know how you people want to see how that issue can be resolved, or so that the healthcare provider has more time and not kind of make the patient feels that they're kind of being rushed. And then Leslie mentioned something about representation in the providers. They wanted to see like diversity and stuff like that. I don't know how we're gonna do that, but if this is something you people can address, that will be fine. And then she also mentioned something as well as Julie, something along the lines where you go to your physician or your doctor, you're complaining of something, you feel there's something going on, but yet you're told that there's nothing going on. So is it like a situation that happens a lot, or is it connected to insurance? They can do certain things or what? I don't know. This is something that you may also want to address. And then coming to Evarista, talking about the language barrier and the lack of education is sometimes a problem. I know that when you go to any facility and they ask you whether or not you speak French, if you said yes, at the end of your visit, they will give you a paper in French. But that sometimes is tricky because not just because I'm able to speak French, I'm able to also read and understand French. Sometimes they're even better in English than in French. But they don't ask those questions, they just, you speak French, they give you something in French or in Arabic. So these are some things that you want to talk about. So the floor, I believe, is open to questions or concerns. Introduce yourself.
Yeah, so my name is Sophia Ortega. I am a nursing student going to graduate in December, this month from University of Utah. Thank you, Madalena, Leslie, and Evarasi, and then Julie for coming. Really reminded me of why I wanted to go into healthcare, so thank you for that. But my question is kind of just more involved with, I'm wondering, do any of the organizations that you work with collaborate with hospitals to talk about culturally competent care? Because I feel like there are a lot of efforts in the hospital. As a student, I see like, they talk about it, but they don't really know the needs of how to best be culturally competent among providers. And so I'm wondering, is there any collaboration with the communities we see here in Utah in cooperation with the hospitals or any other organizations to really fill the needs that our communities need in terms of healthcare? I'm wondering. If not, I can clarify my question. I don't know. I mean, do you guys talk with the hospitals at all?
Talk with the hospital as a community?
As a committee, or like nurse educators, where like, for example, like where you're sharing your stories and you're telling your frustrations of what exactly is happening. Is there any communication that you guys do with or your people in your organizations or in your communities that do that?
Well, let me talk about in my community. Like we have our monthly meetings, and we have, like, for example, if there's a medical opening, medical enrollment for insurance, we always if you have the information, you share it with your community, and then if they have questions, you always write. We have a WhatsApp kind of like a group chat that we put anything there that we want, and we ask people, if you have a question, please come up with it. So, and because I work for the Department of Workforce Services, I have access. I see many things coming in, like jobs and stuff like that. We share it always, but at times it takes like a push to the community. Some of them are relaxed. Back home, the dream was to come to America. They think everything here is milk and honey. It's easy, but now it's the opposite. Some people, their life were much better back home than here. So things are tough. And then some of them do not know how to address it when it comes to their kids and stuff like that. But when we sit as a community, at times in our meetings, we share some stories. We talk about openings, we talk about opportunities, we talk about things that you can buy for less, and including health insurance and stuff like that. But we haven't talked directly to like University of Utah as an institution or any other offices. Yeah.
And if I may add something, yes, actually there are different nonprofit organizations that are trying to address this kind of issue that you mentioned. But of course, there's always room for growth. It's not perfect, but people are trying to do their best. And actually, this is one of the reasons there exists what is called the refuge group, because our mission as a nonprofit is to give refuge to people who are falling through the cracks. We know that the state of Utah is a great state, and it has a lot of services to provide, but still there's some people who fall through the cracks, and this is what we're trying to address as a non-profit organization. And then I know that in other community centers around the valley, they have some educational programs, but the thing that is so ironic about this is because people are trying to give services or education to people, but then on the receiving end, sometimes you will find that there's no lack of interest.
Laxity.
I mean, there are all these resources available, but sometimes people just don't know, and they don't want to go there. And so this is something that I don't know how we can fix. So this is your homework, and try to see how this can be addressed. So this can be addressed so that the services are provided to people more efficiently.
And the Redwood Clinic, one of the community clinics from the University of Utah, sees the most prevalent numbers of refugee patients, and all staff goes through a cultural training. All the new employees and each level of staff goes through that. And we gather information from interpreters like Evereste, resettlement agencies, we do patient interviews. So it's kind of trying to find the time to do the trainings. That's fun. Thanks for trying it.
I wanted to address the issue of interpreters. I'm with my colleagues, and we're all in health communications, and Meredith, my supervisor, can maybe talk get more expertise in this area, but we helped create a training about the availability of interpreters for patients. And the goal is to train every clinician because it is a legal right. And I think patients don't always know that it's their right and that it's a service that we offer. Clinicians don't always know. And there is a limited number of interpreters like here on campus, but there's also a service where we can, it's like telecommunications, because as you mentioned, Mr. Cabrera, there are, just because someone speaks Swahili doesn't mean the interpreter speaks that dialect of Swahili, and it's important to get the right interpreter. Maybe you can talk more about that.
Yeah, I think so. So we're from Huntsman Cancer Institute specifically, and we have I think that university health at large doesn't have, we're kind of a smaller unit, so it's easier to have more, direct more funding to this particular initiative. We have a group internally that does interpreter services. And like Lisa mentioned, we use iPads oftentimes. And I know there's frustration sometimes by the providers that it'll drop a connection and you call back and it picks somebody different. And sometimes the technology doesn't keep up with the human side, and so that can be really challenging. I think it does afford, it's a step in the right direction, I hope. We're at least the service is being offered, because it is, we understand it's a legal right, it's a human right to have medical interpreting available. And I think also to help take the burden off of the children of patients. I know sometimes that can culturally that puts some children in a really difficult position. If they're under 18, it's actually against the law to have them interpret medical information. I'm not sure that I have an answer. I guess it's just, we know it's really hard to have the infrastructure and the buy-in, I think, from the physicians. And that's where I think some of this, we need to take the responsibility. The patient should advocate for themselves always. Advocate for how you feel and advocate for your own body and what you know is right for you. And I think too, we need to put some of this back on the physicians and the care that the system as a whole needs to appreciate that this is a legal right. And it shouldn't be that, well, it's too hard to connect with the iPad. It should be, well, too bad, do it anyway, right? I mean, I really believe that. I think that's something that where maybe as a systematic change where when, we're on the other side of it, making decisions or doing budgets and things like that, we need to put more money behind making it just something that everyone has to do. It's not a choice.
I can chime in too. So I work for the patient experience team, and we get all of you guys' surveys actually. So you have a visit with the doctor, you fill out a survey, and then we get all that information. Please tell us. So this is the kind of stuff that we need. Like, if we are not providing culturally relevant care, let us know, because then we can use the data to pass it on to decision makers to make them know that there is a need for this and that there are baby doctors and baby nurses graduating that want to go into this field and want to be able to provide that kind of service as well, because it's part of the system. It's been implemented into the structure. So please let us know, definitely. And I just wanted to bring up another issue with interpreting, which is the fact that we can get an interpreter, but some cultures will prefer a woman interpreter and some others will prefer a male, depending on the medical appointment. And I think we're at a point where we can get an interpreter, whether that is a real person or an iPad, but we cannot necessarily provide that level of care to patients. So if you're uncomfortable, you are not gonna disclose your women's health issues if you have a male interpreter necessarily. So that's another intersection that we should be aware of. My colleague Anna right here created a tag on Epic where providers and staff can see if a patient has a refugee or asylum seeking status. So it's easier to identify the needs of an interpreter and the gender of this interpreter. So it's little things that we can do popping up across the system to make it better for everybody. But like Meredith was saying, sometimes we're just kind of like clustered and it's hard, but you guys come to our system, you don't care if it's Huntsman or Redwood or whatever, you want to see that care across the system, right? So, yay.
Didi? Yeah, just talking about this, I don't know whether it's something that you can propose for consideration. It's just like accessing medical resources is something, and what kind of access you actually get is another. An interpreter is an interpreter with a simple language. I have confidence when the interpreter is translating to the doctor, but whether the doctor's information is translated to the patient in the right way is another thing, because the medical terminologies, the interpreter might not have it, and then that leaves the client to go home discontent. So, is in the University of Utah, would they be able to do a small kind of, not a department, but something that like small ESL class, but ESL with medical kind of stuff? They do? You do?
We only hire interpreters who are certified through a medical program.
Oh, okay. So do you have them in presented the diversity that you have? Is it all presented in?
We do a bridging the gap.
Bridging the gap.
Yeah. You have to do 20 hours of service, right?
Yeah.
Okay.
Yeah.
And so if there's someone who hasn't gone through that, they shouldn't be interpreted.
That's what I wanted to say. Yeah, you shouldn't allow them to do that.
At university.
Oh, okay.
Is that something that they can report in the surveys that they get when you click on
They
the
can
interpreter?
report preferred language. So we do take in that kind of information. And Mari Ransco, she's sitting back there. She can give us more info on that. She's the director of our department. But yeah, since we're not out in the clinics, I wouldn't know as much about that. Maybe somebody that's involved in like registration can speak about this a little
Are
bit
you
more.
saying whether or not the interpretation was
Yeah, can the patient
accurate?
give feedback on whether the interpreter was adequate or inadequate during their visit?
They can
Yeah.
put any kind of information, any kind of feedback that they have. So we get feedback from parking sucks, food, parking's great, valet, cafeteria food, anything that can be put in your survey. And then as needed, we forward it to the relevant departments. Yep.
But that can be hard if we don't speak English.
Yep.
They can't communicate that more through a survey.
All right, unfortunately, we're out of time. I know it's so exciting, but time just flew by so fast. But yeah, this is just, you can't fix all problems in one day, but this is just a step in the right direction. And we hope there's going to be more and more of these kind of sessions so that we interact with each other and learn about how to better provide services to our clients. And yeah, I think that's all I have to say. Well, thank you so much.